the waiting room. And we are now going for the recording. Good morning, everybody. On behalf of ISA Tamil Nadu, I wish you all, first of all, a very good new year, 2023, and as well as for the Republic Day celebrations. And we are happy to announce that we are continuing our online CME program every month, that is happening on the third Sunday between 11 to 1 p.m. The idea which was started earlier to keep everybody updated, we are continuing the same. And we are very thankful to our academic chairman as the President, Madam, for giving the continuous guidance. With this short introduction, I now call upon the Thuthukudi President, ISA President, Dr. Hari Ramakrishna sir, to give his address.
Good morning, everyone. I thank the organizers, first of all, for giving me the opportunity to deliver the welcome address for this academic feast. Knowledge opens the door to opportunity, achievement, and success. I welcome Dr. R. Amudarani Madam, the President of ISA Tamil Nadu State Branch, taking over to this webinar. I welcome Dr. R. Selvakumar, President-elect, and Dr. N. Bhaskar, the Honorary Secretary, and Dr. Gridharan, the Honorary Treasurer of ISA State Branch, and Dr. S. Kumar, the Academic Chairman. I also extend my warm welcome to the immediate moderators, Dr. Satish Kumar, HOD, the Professor of Cardiothoracic Anesthesiology, CMCH, Vellore, Dr. Swamidas, Associate Professor, Cardiac Anesthesiology, Institute of Postgraduate Medical Education, Kolkata, and Dr. Sai Gopalakrishnan, the Senior Consultant, Cardiac Anesthesiologist, Coimbatore, for this webinar. I welcome the energetic and excellent speakers of this day, Dr. Lynette Shera, Assistant Professor, Department of Associate Professor of Anesthesiology, Government Thuthukudi Medical College, who are waiting for us to share their knowledge. I welcome Dr. Balram Krishnan, our Honorary Secretary, and all my team members of ISA Thuthukudi branch. I wholeheartedly welcome our professors, seniors, colleagues, and postgraduates for this excellent event. The more you learn, the more you earn, the more self-confidence you will have. Let us enhance our knowledge today for the future. Long live ISA. Thank you. Hello.
Oscar, please unmute.
Sir, thank you, sir. Thank you, sir. Thank you. Sorry, I didn't notice that. I thank the President Thuthukudi branch for giving his address. I now call upon our President, Madam Dr. Amudarani, to deliver a presidential address. Thank you. Madam, take on, Madam.
Thank you. Respected office bearers of Tamil Nadu State and other city branches, esteemed chairpersons of today's program, the speakers of today's program, dear ISANs and my dear students, wish you all a happy new year, a very pleasant morning, and warm welcome on behalf of ISA Tamil Nadu to this academic program of first academic program of 2023. My sincere thanks to the Thuthukudi City Branch office bearers and to all the faculties of today's program for sparing your time for us. Executive members kindly concentrate on changing the active members, inactive members to active members. Please kindly convey the message to your city branch members to do the same. On behalf of ISA Tamil Nadu and ISA Tirunelveli, we cordially invite all the members and the students to actively participate in South Zone PG Assembly, which is going to be conducted on February 25 and 26th at Tirunelveli. Which is planned and it has been finalized. I think the flyers are ready. We will be releasing this scientific sessions or schedules very shortly. All the sessions are clinically oriented case discussions and also MGR University exam pattern. We are following the pattern, and we are this time we have included all the afternoon sessions, 4 sessions for discussions. So it will be definitely useful for the postgraduates. So kindly encourage your students, postgraduates to register for the PG Assembly. You all register for the PG Assembly as soon as possible, because the time is very short. I will hand over to the speaker. Long live ISA. Thank you.
Thank you, madam. Thank you for the informative introduction. And as usual, I'll be sharing the Google form to avail the credit hours in the chat box. So anyone who is participating in this online program want to have the credit hours, kindly provide your details only in the Google form. There is the link that is being shared in the chat box. Don't share your details in the chat box. Okay. With this short information, I now hand over the mic to our academic chairman, Dr. Kumar sir, to take further the online programs. Thank you, sir.
Yeah, thank you, Bhaskar. Respected National Office Bearers, past presidents of ISA Tamil Nadu, our state team president, Dr. Amdarani ma'am, secretary Dr. Bhaskar, treasurer Dr. Giridharan, and our president-elect Dr. Selakumar sir. And today's moderators, Dr. Satish, Dr. Sai, Dr. Swamidas, and today's speakers, Dr. Lynette and Dr. Vijayalakshmi, all the branch president, secretary, and treasurers of ISA Tamil Nadu, members of ISA Tamil Nadu, my dear postgraduates. A very good morning to everyone. On behalf of ISA Tamil Nadu, I welcome you all for this wonderful academic meeting. This meeting is organized in association with the Thuthukudi ISA branch. I thank President Dr. Hari Ramakrishnan sir and Secretary Dr. Balram Krishnan for all their contribution and efforts to conduct this meeting. And about today's meeting, we have two interesting topics. One is on perioperative lung protective strategies, and number 2 is on post-operative pulmonary complications. For that, we have very good speakers. Dr. Lynette Thomas, she is an assistant professor at CMC Vellore, and more than that, she is the daughter of Dr. Thomas Koshi, a mentor in cardiac anesthesia. So happy to have Dr. Lynette. And then one more speaker is Dr. Vijayalakshmi. She is known to all of us, and she's a very good friend of everyone. And she's an associate professor at Thuthukudi Medical College. And coming to the moderators, to moderate these two excellent topics, we have excellent 3 moderators. My very good friend Dr. Satish from CMC Vellore, and Dr. Swami Das from Kolkata, and one more excellent and long associate, very good friend, Dr. Sai Gopalakrishnan from Coimbatore. Thanks all the moderators and speakers for accepting our invitation and sparing your valuable academic content to this excellent audience. About the moderators, Dr. Satish is an HOD and professor of anesthesia, cardiac anesthesia at CMC Vellore. I think many of you would know about Dr. Satish. Anyway, for the sake of completion, I have to do, because he is a professor and HOD of cardiac anesthesia at CMC Vellore. His areas of interest are cardiac anesthesia, TE, and bariatric anesthesia. He is a course coordinator for PDF cardiac anesthesia at CMC Vellore, and he has more than 16 publications to his credit. More than that, he is a very good speaker, and for lung, particularly for lung, if you want anything in lung anesthesia, can very well contact Dr. Satish. He will be there to guide you at any stage. Thank you very much, Dr. Satish, for accepting our invitation and taking this program at a next level. And the next moderator is Dr. Swami Das. Swami Das also is a very good cardiac anesthesiologist and more interest in thoracic transplants. She's an associate professor at Department of Anesthesia at IGPMR, Kolkata. Her areas of interest are cardiothoracic anesthesia, thoracic organ transplant, and ECMO. At present, she is serving as a scientific secretary for ACTA West Bengal. Thank you, Dr. Swamidas, for accepting our invitation and to moderate this session. And
Thank you for the opportunity.
Yeah, thank you, ma'am. And our third moderator is my good friend, Dr. Sai Gopalakrishnan. She is a consultant cardiac anesthesiologist. She has a very good cardiac anesthesia experience of more than 25 years in GKNM Hospital. With this cardiothoracic knowledge, he can definitely add great academic content to this meeting. With this introduction of these moderators, I welcome you all moderators and speakers for this academic event. And this format is already, you all know that the first speaker has to complete at least in 25 minutes. After that, we'll have a discussion. And then we'll start the next session. So probably by 12 o'clock, we have to start the second session. And the second speaker will last for 20-25 minutes. After that, we'll have a discussion. And both the talk will complete provisionally by 12:45. So with this, once again, welcome both the moderators and speakers to take this session in active one. Thank you very much.
Thank you, Kumar, for your kind words.
Moderators, please. Thank you, sir.
Thank you, sir. Thank you for a kind introduction.
Satish, you can please proceed in introducing and then take the session to the next.
First of all, I would like to thank the organizers, particularly Dr. Kumar sir and Bhaskar sir, for giving a great opportunity in this ISA forum for the scientific committee to conduct this moderation, and also a good topic to discuss. With this introduction, I would like to welcome Dr. Lynette Thomas. She's an assistant professor in our department, Christian Medical College, Vellore. Very excellent academic, interested student, and also professor now. And she wants to discuss the entire area about the preoperative lung protective strategies. It was already taken in our department also. It's a very excellent topic, and she has done it very nicely. Over to Dr. Lynette. She can take it from here. And all the questions, please put it in the chat box. At the end of the discussion, at the end of the talk, we'll discuss all the questions.
Thank you, sir, for your kind words. Are you able to see the PPT?
Yes, yes.
Good morning, everyone. I'll be talking on perioperative lung protective strategies. So why is there a need for lung protective strategies? So postoperative pulmonary complications account for substantial morbidity and mortality. So the incidence of this ranges from 5 to 33%. There are many risk factors which increase the risk for PPCs. These include patient factors, surgical factors, and anesthesia-related factors. So the patient factors include age greater than 50 years, BMI greater than 40, ASA physical status greater than 2, obstructive sleep apnea, preoperative anemia, preoperative hypoxemia. Coming to surgical factors, laparoscopic surgery, positional changes like steep Trendelenburg also contribute to PPCs. So our topic is anesthesia-related risk factors, which include ventilator-induced lung injury, hyperoxia, IV fluid and blood transfusion-related lung injury. So we'll be talking about strategies to prevent these. Coming to, I'll just give a brief introduction to atelectasis. So atelectasis is the collapse of lung units. It develops through the compression of lung parenchyma, resorption of alveolar gas, and impaired surfactant function. Induction of incidence of atelectasis in general anesthesia is about up to 90% of the population. So induction of general anesthesia and neuromuscular paralysis alters the geometry and function of the diaphragm and chest wall, leading to increased pleural. Excuse me, just 1 second. Yeah. Leading to increased pleural pressure and collapse of dependent lung regions. So another cause of this is resorption atelectasis. It occurs via the continued uptake of oxygen into pulmonary capillaries, distal to closed airways, and can be exacerbated by the administration of high concentration of oxygen. So what are the adverse effects of atelectasis? It causes intrapulmonary shunting, decreased compliance, increased pulmonary vascular resistance, decreased FRC, also increases the driving pressure and increases the susceptibility to inflammatory lung injury. However, you must note that the concurrent inflammation can occur remotely in regions with intact ventilation. So this atelectasis, it can persist for as long as 2 days. Therefore, it likely contributes to the development of PPCs. Coming to ventilator-induced lung injury, so it occurs by 4 mechanisms. That is, volutrauma, it is due to administration of large tidal volumes. Barotrauma, it is due to administration of high inspiratory pressures. So both these cause damage to the, causes over distension of the lung alveoli, causes damage to the alveolar capillary membrane. So this causes release of local inflammatory mediators and causes tissue edema, which escapes into the alveolar space. So another cause of ventilator-induced lung injury is atelectrauma. So this is due to the cyclical opening and closing of atelectatic lung units due to inadequate positive end expiratory pressure. So this also causes a damage to the alveolar capillary membrane and causes release of inflammatory mediators. Another mechanism is biotrauma. This is the release of inflammatory mediators, which causes subsequent fibroproliferative changes in the lungs. So this causes decreased compliance, increases the shunt, causes hypoxia, hypercarbia. And the release of inflammatory mediators can enter the systemic circulation and can contribute to multi-organ dysfunction syndrome because of its transfer to other organs. So coming to the topic per se, that is the evidence-based strategies for perioperative lung protective ventilation. So patient positioning is an important factor. So what happens during supine positioning? It causes cephalad displacement of abdominal contents. This forces the diaphragm upwards and it compresses the dependent lung regions. So this predisposes to atelectasis. So the recommendation is 30-degree head up and reverse Trendelenburg position. This causes less reduction of FRC. So it is better to avoid supine position during induction. So the most important component of a lung protective strategy is the use of low tidal volumes. So it has been shown that large tidal volumes are a major risk factor for lung injury. So multiple studies have demonstrated a significant reduction in PPCs with low, that is less than 6 ml per kg predicted body weight compared to high, greater than 6 ml per kg predicted body weight. Whenever I mention kg body weight, I mean predicted body weight and not the actual body weight of the person. So, however, it is important to note that in these studies, at least 5 centimeter water PEEP was used. So, because the use of low tidal volume and low PEEP or zero PEEP leads to increased lung inflammation and 30-day mortality. So, the protective effect is if you combine low tidal volume with moderate PEEP. These are the various studies which have corroborated the same findings. Evidence shows that there is significantly lower serum markers of inflammation in the lower tidal volume plus PEEP group. And also in one lung ventilation, there is better oxygenation in the lower tidal volume plus PEEP group. And these patients have better oxygenation even with earlier extubation. Larger tidal volumes cause sustained increase in plasma inflammatory cytokines, which predispose to acute lung injury. So as mentioned before, positive end expiratory pressure is an important component of lung protective strategies. It reduces the atelectasis and de-recruitment injury. It improves the compliance of respiratory system, increases the oxygenation and dependent lung ventilation with little to no over distension. So use of at least 5 centimeter water PEEP has significantly decreased the risk of PPCs when compared with less than 5 centimeter water PEEP. This has been demonstrated by various studies. Okay, so these same studies have shown 5 centimeter water PEEP shows better oxygenation, less postoperative atelectasis, and better pulmonary compliance than those receiving zero PEEP. So I would like to mention this trial, Provilo trial, which was conducted in 2014. It is a randomized control trial which compared high versus low PEEP for anesthesia in open abdominal surgeries. So this trial investigated whether 12 centimeter water PEEP was superior to 2 centimeter water or lower PEEP. So this study has mentioned that incidence of PPCs at post-op day 5 was almost identical in both groups. And in fact, higher proportion of patients in the higher PEEP group required vasopressors. So these findings suggest that a high PEEP, such as 12 centimeter water PEEP, is equally as ineffective as low PEEP in preventing PPCs. So this has been supported by various studies subsequently. Hence, if you have to summarize, it is better to individualize PEEP according to the patient and the surgery. Hence, high PEEP may benefit only patients with more severe disease. Higher PEEP is not actually necessary for most of the intra-op population. It can be considered for patients at very high risk for atelectasis or with concomitant lung injury. However, the risk of hemodynamic compromise needs to be taken into account because high PEEP increases the intrathoracic pressure, reduces the venous return, causes low cardiac output. So patients can have hypotension with higher PEEP. So I'll be talking briefly on alveolar recruitment maneuvers. So these are beneficial in reopening collapsed alveoli and improving lung mechanics. So what is alveolar recruitment maneuver? It is a temporary hyperinflation of the lung. So it involves an inspiratory hold with 40 centimeter water of inspiratory pressure for 20 to 30 seconds. This increases end expiratory lung volume, improves compliance, and reduces chest wall elastance. So various studies have shown recruitment maneuvers lead to improved intra-op oxygenation in abdominal surgery, thoracic surgery with one lung ventilation, post cardiopulmonary bypass, and procedures requiring Trendelenburg position. So these are effective when applied after intubation and during any episodes of desaturation, or if there's any release of positive pressure from the breathing circuit. So these benefits are, however, short-lived, as atelectasis might recur within 40 minutes. Hence, repeated recruitment maneuvers are recommended. But however, you should take note that these also can cause hypotension in some patients and should be exercised with caution. So combining all these strategies that we have learned so far, we come to intraoperative lung protective ventilation strategy. It is a combination of tidal volume, 8 ml per kg predicted body weight or lower, and PEEP 5 centimeter water or higher, with or without a recruitment maneuver. It has been shown that this ventilation strategy causes an attenuated release of local and systemic inflammatory mediators as per various RCTs. There is improvement in both intra-op and post-op pulmonary mechanics with this ventilation strategy because of increased compliance and decreased airway resistance. So I'll like to talk about this study, IMPROVE study. They have compared protective ventilation, that is tidal volume, 6 to 8 ml per kg predicted body weight with 6 to 8 centimeter water PEEP, and recruitment maneuvers repeated every 30 minutes with conventional ventilation, that is larger tidal volumes of greater than 10 ml per kg with 0 PEEP and no recruitment maneuvers. So they have conclusively proven that protective ventilation significantly reduces the incidence of PPCs. And there was reduced incidence of pneumonia, need for post-op NIV, and sepsis. Probability of needing post-op mechanical ventilation throughout the 30-day follow-up period was significantly lower for the protective group. So PPV trial, that is a pulmonary surgery with protective ventilation, also mentions similar findings. Patients in the IOLPV, that is intraoperative lung protective ventilation group, had an almost 50% reduced odds of developing a major PPC. So driving pressure, this is a relatively recent concept. It is defined as a difference between plateau pressure and PEEP, that is plateau pressure minus PEEP. It actually is determined by the compliance of the respiratory system. So it is described as a means of normalizing tidal volume to a functional lung size, as it accounts for static compliance. So increasing driving pressure has been shown to increase the risk of PPCs, that is lung injury. So any any maneuver which increasing the PEEP or decreasing the PEEP, increasing the tidal volume or decreasing the tidal volume, anything which causes an increased driving pressure has a significant risk of lung injury. However, further work is needed to confirm these findings. So coming to FiO2, hyperoxia has been shown to cause oxidative stress. Peripheral vascular coronary artery vasoconstriction decreases the cardiac output. It causes resorption atelectasis. It worsens inflammatory lung injury. So FiO2 should be, it's advised to set FiO2 to less than 0.4 with the goal of using the lowest possible FiO2 to achieve normoxia. So that is saturation of at least 94%. Unnecessarily high FiO2 should be avoided. Coming to mode of ventilation, when we compare pressure control ventilation versus volume control ventilation, there are no definitive studies which can say one is superior to the other. So volume control ventilation uses a constant inspired flow. It creates a progressive increase in airway pressure towards the peak inspiratory pressure, which is reached as the full tidal volume has been delivered. So inspiratory pressure during volume control ventilation depends on set tidal volume and PEEP, gas flow rates and resistance, as well as respiratory system compliance. Set tidal volume will be delivered unless the inspiratory pressure exceeds the pressure limit, in which case the flow ceases. So I'd like to show this airflow pattern. This is the square wave flow pattern. So first the inspiratory pressure rises in the beginning to deliver the tidal volume and increase the maximum. So this is the flow which increases in a square wave pattern. This is the pressure. So the pressure constantly increases till the tidal volume is achieved. So this is the peak inspiratory pressure. This waveform actually shows a end inspiratory hold where there is a plateau pressure, where the lung, the air is distributed to the other lung units, and then there is a decrease in pressure. So pressure control ventilation uses the decelerating flow pattern. So there is maximal flow at the beginning of inspiration until the set pressure is reached, after which the flow rapidly decreases, balancing the decreasing compliance of the expanding lung. Here the airflow increases in the beginning and then it decreases depending on the decreasing compliance of the respiratory system. Here, then the pressure attained is uniform, only a plateau pressure is attained. So this resembles a spontaneous mammalian breath. Tidal volumes, however, can be highly variable during pressure control ventilation, and it may fall very drastically with changes in lung compliance, particularly with surgical manipulation. So because the majority of tidal volume is delivered in the early part of the inspiration, mean airway and alveolar pressure tends to be higher during pressure control ventilation. However, the decelerating flow pattern results in a more homogeneous distribution of tidal volume. It improves the static and dynamic lung compliance due to recruitment of poorly ventilated lung regions. It improves the oxygenation dead space ventilation. Since even though studies have shown that there is a lack of clear oxygenation benefit, PCV is likely more preferable over VCV due to the potential to decrease ventilated pressures and the ability to recruit lung units. Coming to emergence from anesthesia, we need to avoid conditions during emergence that negate the intraoperative efforts to recruit and maintain an open lung. I'm sorry, there is some disturbance.
Shilpa, can you mute the others? Where is? One second, madam.
Okay.
One second, doctor. We'll just mute. This is number. Shilpa?
It's from somebody, Nabanita Rai. So
Yeah. Yes, sir.
can you mute the person?
Yes, sir. I muted her, but Shilpa? One second.
May I continue?
Yes, Dr. Lynette, it looks okay now.
Okay. So during emergence from anesthesia,
கொஞ்சம் எனக்கு
Again, it is some disturbances. I think you can go ahead, Lynette.
So during emergence from anesthesia, we need to avoid conditions that negate the intra-op efforts to recruit and maintain an open lung. So we need to optimize the patient positioning. As mentioned before, elevate the head 30 degrees and avoid zero and expiratory pressure. Routine suctioning of the tracheal tube just before extubation should be avoided. This causes the reduction of lung volume. Prevent coughing and bucking on the tracheal tube. Avoid upper airway obstruction after extubation. I can still hear some disturbance. Just keep on continuing. The common practice of turning off the ventilator, allowing carbon dioxide to accumulate to stimulate spontaneous ventilation should also be avoided, as this is associated with zero end expiratory pressure and collapse of alveoli. So the atelectasis that develops during general anesthesia, it persists into the post-op period. So there are other methods of keeping recruited alveoli open, such as application of CPAP during the transition between ventilation and spontaneous breathing. However, studies have not definitively proven improved oxygenation. Hyperoxia, that is FiO2 of greater than 0.8 during emergence, significantly increases atelectasis formation due to resorption atelectasis. So lower FiO2 during emergence can improve the post-op pulmonary function. So CPAP with low FiO2 during extubation may decrease the area of atelectasis. However, studies have not conclusively proven that this is effective. So after extubation, supplemental oxygen should be administered only for saturation less than 94%. For non-invasive positive pressure ventilation, in patients with known or suspected obstructive sleep apnea, use of NIV is an accepted preventive measure. It may also be able to prevent or treat post-op respiratory failure by reducing atelectasis. So, but you should remember that patients with atelectasis benefit more from post-op NIV than those with pneumonia, trauma, or ARDS. So it is necessary to find out the reason for desaturation in the post-op period. Administration of CPAP immediately post-extubation in the obese population has been shown to reduce atelectasis. It improves oxygenation and pulmonary function and may minimize the risk of developing PPCs. High flow nasal cannula. This consists of humidified high flow oxygen with a maximum FiO2 of 100%. It has been shown that at these high flow rate, it provides 4 to 6 centimeter water of added inspiratory pressure. Prospective RCTs have shown that HFNC is comparable to NIV in terms of preventing respiratory failure, and it's actually better tolerated by the patients. However, it may not be enough to combat atelectasis, as the amount of inspiratory pressure needed to reinflate the collapsed lung units may be greater than HFNC can provide. So I'm just going to summarize the recommendations for lung protective ventilation. Use tidal volumes less than or equal to 6 to 8 ml per kg predicted body weight. Apply PEEP of at least 5 centimeter water. Zero end expiratory pressure is not recommended. So appropriate PEEP and recruitment maneuvers may improve intra-op respiratory function and prevent PPCs. Before induction, position the patient with head end elevation at least 30 degrees or reverse Trendelenburg position. In addition to standard monitoring, it is better to have other monitoring of dynamic compliance, driving pressure, and plateau pressure. Before administering a recruitment maneuver, ensure that the patient is hemodynamically stable. Formation of perioperative clinically significant atelectasis is an important risk factor for development of PPCs. Decreasing compliance caused by surgical or anesthesia factors should be treated by appropriate interventions. Recruitment maneuvers can reverse alveolar collapse, but they have to be adjoined with a sufficient PEEP. So if once you do a recruitment maneuver, it's better to connect back to the ventilator and apply sufficient PEEP. Increasing the FiO2 may be effective in increasing the oxygenation, but it is not effective to improve dynamic compliance of the respiratory system. So avoid unnecessarily increasing the FiO2. So coming to fluid management and lung protective strategies, achieving and maintaining optimal fluid balance is challenging in the perioperative period. Too little fluid causes organ dysfunction, hypovolemia, while too much fluid causes edema, anastomotic leakage, and lung injury. So both scenarios are detrimental to the patient. So we need to achieve the appropriate fluid balance. So a study by Licker et al. Has identified that excessive fluid administration during surgery and within the first 24 hours post-op was an independent risk factor for acute early injury. So most of the fluid that we give intra-op actually during surgery actually shifts into the extracellular space, resulting in edema. So to explain this, we need to talk about the endothelial surface layer, which includes the glycocalyx. So this glycocalyx is a barrier to the edema formation. So any disruption of this glycocalyx membrane causes tissue edema. So one of the factors that causes disruption of glycocalyx is atrial natriuretic peptide. It is released in response to iatrogenic volume overload. So if we load the patient with more fluids, it can cause a release of atrial natriuretic peptide, which can directly disrupt the endothelial glycocalyx. So ANP appears to link fluid overload and tissue edema formation by destroying this endothelial glycocalyx. So hence it is recommended not to overload patients in the intra-op period. So the recommendation is to primarily use crystalloids in the perioperative period. Colloids can be reserved for actively bleeding patients in the absence of sepsis and renal dysfunction. Fluid restriction has been shown that it actually does not increase the risk of acute kidney injury in bowel surgeries, provided that you have maintained the perfusion. So coming to ERA's protocol for fluid management, the enhanced recovery after surgery protocol states that fasting of solid food is recommended for 6 hours pre-op. For oral fluid intake for 2 hours pre-op prior to surgery. This has been shown to reduce length of stay and attenuate the insulin resistance. The second component is to restrict intra-op fluid administration to avoid overt hypervolemia. So replacement of fluid losses into third space has largely been discounted. So IRAS advocates that we should limit the fluids to 1 to 2 ml per kg per hour. This is for maintenance and to replace loss of fluid through the skin, airways, evaporation from the surgical fluid, surgical field, and bodily secretions. Additional fluid should only be administered to account for blood loss. So it is important to note that not all episodes of hypotension are due to hypovolemia. So they have recommended that vasopressors can be used instead of intravenous fluids to counteract anesthesia-induced vasodilation and accompanying relative hypovolemia. So NORAD is quite effective in augmenting venous return to heart. It increases stroke volume and cardiac output, raises the mean arterial pressure. These effects should improve organ and tissue perfusion while minimizing the formation of edema. So the ERAS protocol has shown that perioperative hemodynamic optimization using a combination of fluids and inotropes was effective in reducing acute kidney injury after surgery. Also, excess positive fluid balance in the post-op period should also be avoided. IV fluid administration should be terminated as soon as possible, with the resumption of oral hydration and alimentation as soon after surgery as is safe. So this is the summary of fluid management. We can encourage the patient to have as much clear liquids as possible up to 2 hours before surgery. Fluid administration the first 24 hours should be less than 2 ml per kg per hour. Perioperative positive fluid balance should be less than or equal to 1.5 liters. Vasopressors or inotropes as needed for anesthesia-induced vasodilation or ongoing hypoperfusion. And mechanical ventilation should include the lung protective strategies as we have discussed before. So there is apparent synergism between volume status and mechanical ventilation strategies. Hence, we need to use lung protective ventilation along with judicious perioperative fluid management in the patients undergoing abdominal surgeries. So hence, it's better to have smaller intracrystalloid maintenance infusions, judicious colloid boluses just to replace the blood loss, use of vasopressors, inotropes to combat relative hypovolemia due to anesthesia, and there is a focus on limiting post-op positive fluid balance. Thank you.
Thank you, Dr. Leonard, for an excellent presentation and covering the entire area regarding the lung protective strategy, including the fluid management. Both go hand in hand. It is not only managing the lung. We have to protect the hydrostatic pressures by giving less fluids and if appropriate use of vasopressors so that the lung injury will be really reduced in the post-operative patients. It's not only for abdominal surgeries. It can be extrapolated to other cardiac, lung surgeries and other major surgeries which extends more than 1.5 to 2 hours. There are a few questions for you, Dr. Leonard, in the chat box. The first question, how to do the proper recruitment maneuver?
Okay, so it is by it includes a positive inspiratory hold of at least 40 centimeter water for at least 20 to 30 seconds. So we keep on. Can you hear me, everyone?
Yeah.
Yes, madam, we can hear you.
They are very well,
Please proceed.
Uh,
very well audible.
Okay, so that positive pressure, you take the bag in your hand, keep on bag mode, increase the flows. So keep at least the valve open to at least 40 centimeter water and hold for at least 20 to 30 seconds. However, when you do this, you should make sure that there is no hemodynamic instability before you do this procedure, as it can cause significant hypotension.
Yeah, this is very important. The prerequisite is make sure the patient is not hypovolemic or hypotensing before doing the recruitment maneuver. That's also very important. Otherwise, the moment you start, it will cause significant hypotension. That's great. The newer machines are actually as this recruitment maneuvers as a program. GE machines. If you put recruitment maneuver for 30 seconds with 30 or 40 centimeter water, it automatically gives. You don't need to disconnect from the ventilator also. So all those facilities are available in the newer machines. Thanks, Leonard. The next question is, how do you calculate predicted weight?
Okay. Predicted body weight. For males, it is 50 plus 0.91 into height in centimeters minus 152.4. In females, it is 45.5 plus 0.91 into height in centimeters minus 152.4. So this is one formula to calculate the predicted body weight.
Yeah, the height is very important because the short patient with very significant body weight, we should not give the volume according to that. Thank you. The next question from same person, Vijay Raghavan, to you. How to calculate plateau pressure?
Plateau pressure, it is what you need to do is keep an end inspiratory hold at the end of while giving a normal tidal volume breath. Keep an end inspiratory hold for at least 5 to 10 seconds. That will normalize the pressure across the ventilation of the lung units, and that will calculate the plateau pressure.
Yeah, basically it shows the complaints of the lung. Initially an inspiratory pressure, which suddenly go up to a plateau pressure, peak pressure, and then it slowly reduces to a plateau. So that plateau pressure is very important rather than the peak pressure. That gives the real ventilation of the distal pulmonary units and keeps the alveoli open during the procedure. Okay, and one more question has come. Which is your crystalloid of choice?
Balanced crystalloid fluids like ringer lactate is the recommended fluid. Fluids like plasma light also can be given.
Okay. So balanced crystallized solutions like ringer lactate or plasma light. Okay. Is there a possibility of hypercarbia occurring while giving post-op CPAP in obese patients? Is BiPAP better?
Yes, BiPAP is better. In order to bring the CO2 down, we need to actually positively ventilate the patient. So NIV has been shown that it is better in the obese population after surgery to maintain their ventilation, to reduce atelectasis and to maintain normocarbia.
Okay. In our centers also, we also do use this CPAP, but if the patient is already preoperatively on any nasal CPAP, it is better to ask those patients to bring their CPAP equipment and keep it in the recovery room, because they are used to that mask and it is very easy to apply. And no point in reducing the CO2 level significantly. If the preoperatively, if the patient has some CO2 drive, if we reduce the CO2 below the normal, whatever the baseline for the patient, the ventilatory stimulation will come down. So suppose the baseline is around 45 to 50, maintain that 45 to, they are used to that 45 to 50. No need to reduce less than 40. Then they may stop ventilation. That's also we have to take into consideration. Okay. Next, what is your guide for intravascular volume replacement status? How to monitor them? Is invasive modality preferred?
Invasive modality, it may be required in some patients as per the needs of the surgery, but it is not really recommended for general population. So what you need to maintain is perfusion. So maintain normotension. Basically, you should prevent hypovolemia, hypotension by maintaining the perfusion with inotropes or vasopressors, even if you are restricting the IV fluids. So
that's great. The chasing urine output every hour, that may not be the real recommendation nowadays. But if you have a PPV, pulse pressure variation, or SVV, stroke volume variation possibility, even with the pulse oximeter, or if you put an outline, it can be incorporated in the many monitors. Even the simple monitors also have that facility. That will give an idea. Particularly that is the positive pressure ventilation causes significant positive pressure variation, then you may need to give some volume rather than blindly giving the volume. Okay. Yeah, somebody mentioned the recruitment maneuver described is just like giving Valsalva in neurosurgeries to check any bleeding. I think it's almost similar, but in neurosurgery, we give for more sometimes a shorter duration, because we cannot keep on giving for that. But in recruitment maneuver, you need to give for the 30-40 seconds. If you don't give for such a long time, the recruitment may not happen appropriately. One more question, Doctor. Ideal time to do. Which is the ideal time to do recruitment? Before extubation or after intubation?
Whenever there is a period of desaturation intra-op, you can do a recruitment maneuver. However, atelectasis can recur within 30 to 40 minutes. So it may be advisable to do repeated maneuvers throughout surgery, provided that patient is hemodynamically stable.
Yeah, in your lecture also you mentioned that each recruitment maneuver lasts for almost 40 minutes. So every 40 minutes to 1 hour, if you can do a recruitment maneuver, particularly steep Trendelenburg push in patients, like colorectal surgeries, robotic surgeries, urology surgeries, it's really, really useful for lung protection. I think we are done with the questions. Really answered well, Dr. Lynette. Thank you for your presentation.
Dr. Satish, I have a few questions.
Yeah.
Firstly, Dr. Lynette, congratulations. It was a very comprehensive presentation. But I have a few questions with regards to what FiO2 would you recommend we keep once we intubate the patients and keep on mechanical ventilation? Is there any target, something we see?
Less than 0.4. According to these recommendations, less than 0.4 is the ideal FiO2 to be kept.
And what would you recommend the target SpO2 to be?
At least 94%.
At least 94%. But I as mentioned in one of the guidelines, I guess it's not 100%. It's like 95%, 94%. We should be happy with that, rather than going for 100% FiO2 induced absorption atelectasis. Another question is, would you recommend which is more preferred as per you, a manual ARM, airway recruitment maneuver, or a ventilator driven recruitment maneuver? And what would be the FiO2 you would be preferring while using these recruitment maneuvers?
So, if the facility for ventilator-driven recruitment maneuver is there, that is preferable towards over the manual recruitment maneuver. And the FiO2 should be preferably kept below 0.4%. 0.4, sorry.
Thank you. And would you recommend any specific ventilatory mode while ventilating routinely our patients undergoing surgery?
As mentioned in my slides, so no studies have shown that volume control ventilation or pressure control ventilation is superior to the other. But however, I would like to say pressure control ventilation is better, as the inspiratory pressures reached are much lower, and there is a better redistribution of the air into the entire lung units. So
correct. Studies show mixed results actually. And would you have anything to say about the PROBEASE trial, which they have done on obese patients undergoing surgery, and they found out that using of a high airway recruitment maneuvers didn't really help much in improving the ABGs, blood gas analysis. Would you have something to say about that?
Actually, what I've read is in obese patients, they need at least the higher inspiratory pressure of at least 50 centimeter water compared to 40 centimeter water in the general population. So I guess we need more studies which show that there is improvement when you use these higher pressures for obese patients. So
thank you very much.
Thank you, Swamidas, Dr. Swamidas, for bringing those points. I have noticed in GE machine, there is one mode called pressure control volume guaranteed. And in Dragon machine, there is an auto flow volume mode. So those two modes take care both the positiveness of volume and also pressure. And it gives a better mode of compliance for, even if the lung is slightly injured and if the patient has complaints is less. This mode protects the lung by giving a reasonable tidal volume, but also not increasing the mean airway pressures. So, but not all the machines will have that facility. If you have, better to use it.
So this is for the benefit.
Would you recommend a specific IE ratio? I mean, in literature, they have not mentioned any. A prolonged inspiratory time probably reduces the peak mean airway pressures. So do you have anything to say about that? What as per your experience?
Dr. Lynette, do you want to comment about it? IE ratio?
IE ratio can be tailored to the patient. So in patients with COPD, they may benefit from increasing the expiratory time. So you can increase, change the IE ratio from 1:2 to at least 1:4 also, to increase the expiratory time and drive out the carbon dioxide. So in patients having hypoxia, so it's better to increase the inspiratory time. So inverse ratio ventilation, like 2:1, can be recommended for these patients. So,
thank you.
Thanks, doctor. Yeah, basically you need to see whether it's a distal alveolar units or the tubules, the bronchi and bronchioles are causing problem. COPD is a bronchial and bronchiolar problem. So there you need to increase the expiratory time. But if it is due to alveolar issues like some fluids or atelectasis or some increased hydrostatic pressure, there you have to increase the inspiratory time. Then the ventilator pattern will change. Yeah. Sir, Bhaskar sir, do you want to mention anything?
Nothing, sir. Just I wanted to recap how to do the recruitment, but for the recruitment maneuver for the benefit of the postgraduates in this session, sir. Can you just recap on how to do the recruitment maneuver if it is not in the machine when you are going to do?
Manual. Dr. Lynette, if they want the manual mode of recruitment maneuver, can you explain in crisp and short?
Okay. So first, it is important to ensure that the patient is hemodynamically stable. So make sure that the patient is not hypovolemic or hypotensing before using this alveolar recruitment maneuver. So put on bag mode, increase the flows to at least 6 liters per minute. So keep the valve to at least 40 centimeter water and keep an inspiratory pressure hold for at least 30 seconds, 20 to 30 seconds. That is the recommended maneuver. Once you release the pressure, connect back to ventilator immediately to maintain the positive pressure.
Thank you. Thank you, doctor. Thank you very much.
That is very important, sir. The moment you give the positive pressure, don't immediately collapse the bag. You immediately put on ventilator mode so that recruitment will maintain. If you again collapse and put on ventilator, then the whatever recruitment done also will go off. So that is extremely important to do that.
Yes.
Thank you.
Thank you, sir.
So if the first session is over, then I think we can move on to the second session. This is by Dr. Vijayalakshmi from 22JAN Medical College, Assistant Professor. I call upon Dr. Saumidas Madam to give introduction on the speaker, and we can proceed with the session, sir. Madam, unmute, madam.
Thank you. Dr. H. Vijayalakshmi is an Associate Professor of Anesthesiology of Government, Thoothukudi Medical College, and she is qualified anesthesiologist having done MD Anesthesia from Madurai Medical College. She has worked as an assistant professor at Madurai Medical College for 9 years, and she will be speaking on the topic of post-operative pulmonary complications. I will welcome Dr. Vijayalakshmi to please start her presentation.
Thank you, ma'am.
Is there any problem, Vijay?
Oh, 1 minute, ma'am. 1 minute, ma'am.
You're trying to share the screen,
Yes,
right?
ma'am. Yes, ma'am. Yes, ma'am.
Yeah. If you want any help, you can get a help from Shilpa. Shilpa, are you there?
She's there. She's there, madam. Shilpa's there. Or
Am I audible, ma'am?
Yeah,
very
yeah.
much, madam. Yeah, very clearly.
Yeah, you can start.
Yes, ma'am.
Yeah.
Yes, ma'am.
Yeah.
Yeah.
Morning, ma'am.
Yeah, good morning.
First of all, I would like to thank our Tamil Nadu ISA and members of Tamil Nadu ISA and Thoothukudi ISA for giving me this opportunity. So today's topic is about postoperative pulmonary complications. So why are we worried about this postoperative pulmonary complications? First of all, I'll tell what are the topics I'm going to cover today. So I'll talk about incidents, what are the respiratory changes under general anesthesia and under regional anesthesia, then topic per se, postoperative pulmonary complication. Then we'll talk about the preoperative risk stratification and how to manage it. So first,
Madam, excuse me, madam. Madam,
Yes,
excuse me, madam. You can go for the full screen mode, madam. That is in the lower part of the screen. You're in the computer. There is no
Yes, sir.
just above, madam. Just above. Next, the fourth button. Go for the fourth button. Yes, madam. Now you can go in.
Yes, sir. So, postoperative pulmonary complication is a term used to describe any complication that is affecting the respiratory system after anesthesia and surgery. So, nearly 2/3 of major anesthesia-related post-anesthesia care unit admission are due to respiratory problems. Then the incidence ranges from 1% to 23%. So, what is the impact of this respiratory complication? It causes prolonged hospital stay, cost, and also increases the morbidity and mortality. So, what are the respiratory changes following regional anesthesia? So, changes in inspiratory function are minimal, except for a slight decrease in vital capacity. In the absence of sedation, the minute volume, tidal volume, respiratory rate change a little. So, the expiratory muscle function is reduced in proportion to level of spinal anesthesia, and paralysis of abdominal muscles leads to impairment of coughing and clearing of secretions. So, coming to respiratory changes in general anesthesia, previous speaker talked about this, and the intraoperative changes in respiratory function are: first, the central respiratory drive is depressed, and ventilatory response to hypoxia and hypercarbia is impaired. So, if the patient is left in spontaneous ventilation for some period, definitely hypoxia, hypercarbia will develop. So, it is better to control the ventilation after giving the opioids, induction agents. Then, cephalic displacement of diaphragm and the increased curvature of spine and the reduced cross-sectional area of the chest wall, all these factors lead to reduction in functional residual capacity. And altered VQ ratios. And what are the reasons for development of atelectasis under general anesthesia? Due to direct compression of lung tissue as diaphragm ascends up, and airway closure occurs when FRC is reduced below closing volume. Then rapid absorption of gases from the alveoli in areas where the airways are narrowed or closed. All these factors will lead to atelectasis. This picture shows once the patient is anesthetized, diaphragm moves up and the curvature of the spine also changes, leads to airway closure. Then the reduced lung volume and electrolysis contribute to postoperative changes. So continued reduction in FRC reaches its lowest value in 1 to 2 days after surgery, and it returns to normal values within a week. Atelectasis persists for at least 24 hours in patients undergoing major surgery, like any abdominal aortic aneurysm or thoracic surgery or surgery near diaphragm. And the respiratory muscle activity is impaired following major surgery due to anesthetic agents and non-depolarizing muscle relaxant, then due to pain in the surgical site. And effort-dependent lung function tests like forced vital capacity, forced expiratory volume in 1 second, and peak expiratory flow rate, all are reduced significantly after surgery. So, when does the changes reverse? Reversal occurs, after minor procedures, it reverses within few hours. But following major surgeries, it may take many days. So, coming to risk factors for the postoperative pulmonary complications. So, it is either patient factors, procedure factors, or laboratory investigations wise. So, coming to patient factors, it is divided into non-modifiable factors, modifiable factors. So, non-modifiable factors are age more than 60 years, male sex, then impaired cognition and sensory. If the patient is having any previous history of cerebrovascular accident also, the chance of postoperative pulmonary complication is more. Then, if the patient has got history of malignancy, so these patients will be debilitated, their albumin level may be low, they may be in a hypotensive state. Then weight loss, if the patient has got a recent weight loss of more than 10%, then if the patient is taking long-term steroids and acute respiratory infection within the last 1 month. So it is better to wait and then take up these sort of cases in order to reduce the postoperative pulmonary complication. And coming to modifiable risk factor, smoking is definitely a modifiable risk factor. So stopping smoking for carbon monoxide, half-life of carbon monoxide is carbon monoxide and nicotine is within 12 hours. So if the patient, we have to advise the patient to stop smoking for at least 12 hours. And chronic obstructive pulmonary disease also, we can optimize these patients before surgery. Then congestive heart failure, and more important is the patients who have got obstructive sleep apnea. So these patients may be using CPAP machine in the home itself. So we have to advise these patients and they have to bring it to the hospital also. So after extubation also, we can advise them to use post-operative CPAP to avoid these complications. Then body mass index of more than 27 kilograms per meter square. Then known case of hypertension, chronic liver disease. These patients have liver disease patients, they have reduced albumin levels. So muscle function may be impaired. So reduced, delayed recovery from the muscle relaxant. So postoperative complications may be increased. Then coming to renal failure and diabetes patients also, they are more prone for respiratory infection in the postoperative period also. Then coming to procedure factors, they are also divided into non-modifiable factors and modifiable factors. So the duration of procedure should be limited. If it is more than 3 hours, the chances of developing postoperative pulmonary complication is more. And the surgeons, they should limit if the case is a high risk case and it is more prone for a postoperative pulmonary complication means senior surgeon should do the surgery and the duration of the procedure should be reduced. And type of surgery. So, as previously mentioned, abdominal aortic aneurysm or major thoracic surgery, major abdominal surgery, chances of postoperative complication is more, as the movement of diaphragm may be impaired due to incisional pain and reduction in functional residual capacity. Then emergency surgeries. See, as the patient lands in an emergency, will not be having adequate time to optimize the patient. They may be in having any respiratory infection, or patient may be hypovolemic, coming in hypotension. Then resurgery. If you are taking for any redo like anastomotic leak, then multiple general anesthesia following admission also carries additional risk of postoperative pulmonary complication. Then modifiable factors are ventilation strategy. As my previous speaker told, ventilation strategy is with a tidal volume of 6 to 8 ml per of ideal body weight. Then PEEP of optimal PEEP or ideal PEEP around 5 centimeter of water. Then we can non-depolarizing muscle relaxant. We can go for a short acting, intermediate acting muscle relaxant. That too with the help of we can use a peripheral nerve stimulator. Then we can avoid long acting muscle relaxant like pancuronium. Then intraoperative blood transfusion. Chances of development of acute lung injury or transfusion related lung injury is more. Then perioperative nasogastric tube. Sometimes for protection of anastomosis, then for easy bowel movement, sometimes mostly they advise perioperative, surgeons want to use Riles tube, but they also carry additional risk factor of perioperative risk of aspiration. So this also carries additional risk for postoperative pulmonary complication. Next is abnormal liver function test, as I have already mentioned, and raised blood urea creatinine and preoperative anemia. That is also a very important factor. So if the patient has pre-op anemia less than 10 grams per liter, it should be corrected. Either we can supplement with iron oral tablets, or we can go for iron sucrose, correct the preoperative anemia, and then we can post this patient for surgery. The oxygen carrying capacity is also reduced in anemic patients as hemoglobin content is reduced. Then coming to other factors like low preoperative saturation. If the preoperative saturation is less than 96%, this patient carries an additional risk of postoperative pulmonary complication. Then I raised liver function, renal function test also I have talked earlier, like raised urea, raised creatinine. Then coming to topic proper. So postoperative pulmonary complications can be either it is airway obstruction or hypoxemia, or it is hypercarbia. So first we'll talk about airway obstruction. So airway obstruction can be mechanical, or it is due to airway edema or laryngospasm, or residual neuromuscular blockade, then foreign body aspiration, or it can be a neck hematoma or vocal cord paralysis. So we'll discuss it one by one. So first it is mechanical airway obstruction. So it occurs due to tongue fall or indrawing of pharyngeal muscles, or by blood or secretions in the pharynx. So characterized by labored breathing, chest wall retraction, nasal flaring, snoring, if obstruction is severe, that is absent breath sounds, paradoxical chest movements, stridor, wheezing, tachycardia, and hypertension. So this picture shows an unobstructed airway and an obstructed airway. As the muscle tone is lost after giving our opioids, after induction of anesthesia, muscle tone is lost. So genioglossus, it obstructs the tone is lost, so it obstructs the airway, patent airway. Next, laryngeal obstruction can also occur due to laryngospasm or direct airway injury. In any case of airway surgeries like vocal cord polyp removal and vocal cord paralysis, it can occur following total thyroidectomy due to nerve injury, and it can occur immediately after extubation or in the post-anesthesia care unit. So it occurs due to stimulation of glottic structure by secretion or airway equipments in lighter plane of anesthesia, characterized by high-pitched inspiratory stridor. If it is a complete laryngospasm, means there is absence of sounds. So next is airway edema. So it can occur following, as I mentioned about previously, any surgeries in the head and neck surgeries or in the vocal cord itself. Then airway instrumentation, if it is a difficult airway, difficult intubation. Then prolonged prone position or prolonged head-on position or combined. Then residual neuromuscular blockade. So patient will be manifesting with an inadequate head lift, rapid shallow breathing, jerky movements, and wound hematoma following carotid or thyroid surgery or spine surgery. Then in a long-standing goiter, if the patient is coming for thyroidectomy, postoperatively patient can develop tracheomalacia, collapse of trachea, and leading to respiratory complication. Then foreign body aspiration, any left undetected throat packs or swabs and dentures, blood, any secretions, this and also cause foreign body aspiration and aspiration pneumonitis. So coming to management of airway obstruction, we are going to supplement with oxygen, and head tilt and jaw thrust moves the genioglossus away from the pharynx. And if this manner is not adequate to maintain the patent airway, you can go for a oral or nasopharyngeal airway. You can also place the patient in the recovery position, in the lateral position. Then laryngospasm. So similar to airway obstruction, we can do an anterior mandibular displacement, give a dose of steroid, dexamethasone or hydrocortisone, positive pressure ventilation, and CPAP. If it is not possible to maintain oxygenation, means you can go for a small dose of propofol, or if you are not able to ventilate the patient, means you can go for a dose of muscle relaxant, re-intubate the patient and wait till the patient recovers, and then you can extubate the patient. And airway edema, head up position, use of humidified gases, giving a dose of steroid, then you can nebulize the patient with epinephrine. Then neck hematoma, as in the case of carotid endarterectomy or any thyroidectomy surgeries, needs immediate evacuation. Then next, coming to the next topic, that is hypoxemia, occurs due to, as already I have mentioned, atelectasis, then pulmonary edema, pulmonary embolism, pneumothorax, pulmonary aspiration, and bronchospasm. So first, hypoxemia manifests as cardiovascular manifestation will be tachycardia, arrhythmias, hypertension. Respiratory system has increased respiratory rate, pulmonary artery, increased pulmonary artery pressure. Central nervous system, confusion, restlessness, obtundation. So ventilation, perfusion abnormalities. So previously we have seen the respiratory changes under anesthesia. So FRC is reduced during and immediately after anesthesia, and the closing capacity may encroach on the tidal volume breathing, leading to reduced ventilation. And areas of lung with increased ventilation perfusion ratio constitute the physiological dead space, and areas of with reduced ratios increase the venous admixture, leading to hypoxia. Next will be shunt. So physiological shunt may be increased in the immediate postoperative period, and prolonged intraoperative hypoventilation. Sometimes a junior PG may be ventilating, prolonged hypoventilation, and with a low tidal volume. Then uninterventional endobronchial intubation also. Then shunt is also increased in the late post-op period due to underventilation of the lung bases due to pain. And bronchial obstruction by secretion also leads to lobar or segmental collapse. Then diffusion hypoxia. So this commonly occurs immediately after extubation. So nitrous oxide is 40 times more soluble than nitrogen in blood. After discontinuation of nitrous oxide, after the case is over, it diffuses out of blood into the alveoli in large volumes than nitrogen diffuses in opposite direction. So the alveolar gases, both oxygen and CO2, both are diluted. PaO2 is reduced. So this leads to diffusion hypoxia. So if you want to avoid it, you have to keep 100% oxygen at that time. But literature says that it is better to go for 80% FiO2 than giving 100%. If you want to give 80% means air oxygen mixture is needed at that time. Coming next to pulmonary edema, features are dyspnea, tachypnea, hypoxemia. So commonly it can occur within 30 minutes or 60 minutes of completion of surgery. So features will be basal crepitations. Other than that, X-ray findings will be there. Then if it is a cardiogenic means causes will be cardiac dysfunction, cardiomyopathy, hypertension with concentric LVH, high central venous pressure. It can be non-cardiogenic pulmonary edema, as in the case of aspiration pneumonitis or ARDS. And another important thing is negative pressure pulmonary edema due to prolonged airway obstruction. The rise of carbon dioxide immediately will be first minute it will be 6 millimeters of mercury, and the next minute from next minute it will start rising by 3 to 4 millimeters of mercury. So if the patient is a muscular individual also, the chance of developing negative pressure pulmonary edema following an airway obstruction will be very high. And this picture shows the cardiogenic and non-cardiogenic pulmonary edema. So in a non-cardiogenic, mostly the infiltrates are in the lung base. Then here it is diffuse bilateral patchy infiltrates distributed throughout the lungs. Next will be pulmonary embolism. So if the patient is bedridden for a prolonged time, as in a major surgery, or patients who have undergone joint replacement surgery, elderly patients, they are more susceptible. So sometimes patient after LSCS or any case, after 1 or 2 days, they'll start mobilizing the patient. At that time, there is more chance of development of pulmonary embolism. So patient will have dyspnea, tachypnea, tachycardia, hypotension, increase in central venous pressure. And either it can be air, fat, embolia, or thrombus from a peripheral vein. So management, so you have for hypoxemia, given high concentration of oxygen. So for pulmonary embolism, you can immediately thrombolyze the patient with streptokinase also and intravenous heparin. Then you can go on with an oral anticoagulant therapy. If needed, you can go for open pulmonary embolectomy also. Then coming to management of pneumothorax, pneumothorax. So it can occur following rib fracture, flail chest, and surgery near diaphragm. Then central line placement and intercostal block and brachial plexus block. Nowadays we are going for ultrasound guided blocks, but you have to be careful. If pleura is pricked, immediately patient will cough. The features are tachycardia, dyspnea, tachypnea, unequal breath sounds, and high peak inspiratory pressure, hypotension. So X-ray shows partial or complete lung collapse. So sometimes this may develop into a tension pneumothorax, leading to hypoxemia, mediastinal shift, reduced venous return, impairment of cardiac output. So pulmonary edema will be managed by using diuretics like furosemide, morphine, then fluid restriction. If ventilation is needed, you can intubate the patient and ventilate. The pneumothorax, 10 to 20% of pneumothorax spontaneously resolves. If it is more than 20% in spontaneously breathing person or any pneumothorax in mechanically ventilation patient should be treated. So initially, if it is think that it is a tension pneumothorax, you can insert a 14 gauge needle into the second intercostal space at the midclavicular line. Then treatment per se, you can go for a ICD insertion in the fifth intercostal space anterior to the mid axillary line. Then other complications are acute lung injury or TRALI, that is transfusion related acute lung injury. So acute non-cardiogenic pulmonary edema associated with dyspnea and arterial hypoxemia can occur within 1 to 2 hours or can occur up to 6 hours after transfusion. So next will be bronchospasm. So it can occur due to stimulation of airway by inhaled material. So it is common in asthmatics, bronchitis patients, smokers. So the drugs like barbiturates, morphine, mivacurium, atracurium can also precipitate bronchospasm. So treatment, oxygen supplementation. If intraoperatively it develops means you can deepen the plane of anesthesia, give administered inhalation agent like sevoflurane, And post-operatively, bronchospasm develop means you can go for a nebulization, give a dose of steroid, then beta agonist. We can give epinephrine also, nebulization. Next will be hyperventilation. So hyperventilation leads to hypercarbia. So mild hypercarbia, there will be no major consequences. If it is moderate, that is more than 50 millimeters of mercury, tachycardia, hypertension, headache, nausea, sweating, agitation occurs. If the PSCO2 is raised above 80 millimeters of mercury, somnolence, arrhythmias, myocardial depression. Arrhythmias occur due to release of noradrenaline from the myocardium. So that will lead to arrhythmias. So causes of hyperventilation will be poor respiratory drive due to the residual effects of opioids and poor respiratory muscle function due to residual effects of muscle relaxants. Other cause of high rate of production of carbon dioxide can be due to fever or malignant hypothermia, shivering, carbon dioxide insufflation as in the case of laparoscopic procedures. Central respiratory depression, as I mentioned, it is due to anesthetic agents and opioids, and a significant amount of drug remain in the brainstem during the early postoperative period. Residual neuromuscular blockade manifested by uncoordinated jerky movement, and it is exaggerated by disease of neuromuscular junction, myasthenia gravis, or by electrolyte disturbances like hypokalemia. So I have mentioned about this in the previously factors which precipitate or which are predisposing factors for development of postoperative pulmonary complication. So inadequate excretion of the muscle relaxants due to renal failure, hepatic failure, or it can be prolonged due to aminoglycoside antibiotics like gentamicin, neomycin, hypermagnesemia, hypothermia, metabolic acidosis. And another important factor of hyperventilation is splinting due to pain at incision site, then gastric dilatation, tight dressings and body cause. They also inhibit the respiratory muscle function. So narcotic-induced respiratory depression can be reversed using naloxone, but it should be reversed in a titrated manner so that if pain occurs, that will lead to tachycardia, hypertension. So crisis at that time, crisis can occur. So you have to reverse it slowly. So titration of small dose and increasing the dose upward until an effect avoids a sudden onset of severe pain. That will lead to reflex tachycardia and hypertension. So pain relief can be given using epidural analgesia, nerve blocks, or non-steroidal anti-inflammatory drugs. So we have seen about the about postoperative pulmonary complications, either life airway obstruction, hypoxemia, or it is hypercarbia. So the reduction in tidal volume, functional residual capacity, and increase in closing volume, all these factors lead to atelectasis, reduced lung complaints, increased work of breathing, muscle fatigue, then respiratory failure. Then inability to cough and impaired mucociliary activity also occurs in the after GA also. Then retention, this leads to retention of secretion. Then infection, pyrexia, increased work of breathing, increased oxygen consumption, then muscle fatigue and ventilatory failure. Then per se treatment will be oxygen therapy. Either you can go for nasal cannula in the postoperative period, or you can go for face mask O2 or non-rebreathing mask, or we can administer if the patient, as I already mentioned, if the patient is having obstructive sleep apnea, can administer CPAP also, continuous positive airway pressure. Then intensive physiotherapy. And if the patient has got pneumonia or aspiration pneumonitis, then tracheobronchitis, we have to administer antibiotics accordingly. Then we can investigate also, like sputum culture sensitivity can be done. Then ventilator support, if we are not able to manage with these sort of maneuvers, we can go for ventilatory therapy. So coming to measures to reduce the postoperative pulmonary complications. So preoperative modifiable factors, as I have already mentioned, smoking should be definitely discouraged. Then respiratory infection in the recent 1 month, it should be, or whenever the patient comes for a pre-anesthetic assessment, if the patient has got a respiratory infection, treat it, then we can take the case. Then if the patient is morbidly obese, you can advise for weight loss also. Then COPD patient should be optimized before surgery. We can ask them to take like a nebulization, bronchodilators. Then they should be advised about the next coming to, I'll talk about it next. Then anemia correction, as I have already mentioned. Then preoperatively physiotherapy interventions. Then we have to educate the patient on the post-operative breathing exercises. In the pre-op assessment itself, we have to tell them. Then inter-op consideration. At induction, we have to be careful not to introduce infection by any contaminated equipment. You have to use sterile suction tubes, suction catheters, and anesthetic gases should be humidified. You have to avoid dry administration of dry gases. Then you have to ensure the adequate antagonism of neuromuscular blockade. Never be in a hurry to reverse the patient once the surgery is over. We know that drugs will be eliminated in a particular time. So wait till that time, then you can reverse the patient. Then ventilation, as I've already mentioned, ventilation with a 6 to 8 ml per kg of ideal body weight. Then use of optimal peak. We have to avoid atelectasis and also we have to avoid volutrauma. Then post-operative consideration, incentive spirometry should be given. Then coughing, deep breathing exercise, postural drainage, good oral care should be given to the patient. Then understanding, patient should be educated. Then early mobilization and head end of bed should be elevated for 30 degrees. Then another important factor is giving adequate analgesia so that splinting and the other factors like reduction in FRC, atelectasis will not happen. So give adequate analgesia to the patient. Then if needed, you can go for a CPAP or BiPAP. Thank you.
Thank you, Dr. Vijay Lakshmi. That was a very good presentation.
Thank you, ma'am.
Thank you very much. There are a few questions from the audience I see in the chat box.
Yes, ma'am.
To begin with the first question, what is the level? Do you think that there is any correlation with the albumin level and the occurrence of post-operative pulmonary complications as has been said in many textbooks?
Yes, ma'am. Less than 3.5 grams, ma'am.
Yeah.
Yes, ma'am.
Yes. So that's a recommendation actually, to keep
Yes,
the albumin above 3.5
yes,
gram,
yes,
and
above,
good
yes.
poor nutritional status is indeed associated with increased occurrence of pulmonary
yes, ma'am.
complications.
Post-operative pulmonary complications.
Yes.
Yes.
So your next question is, you mentioned about laryngospasm, post-intubation laryngospasm.
Yes, ma'am.
So somebody is asking, Dr. Prithvi is asking, how do you prepare the epinephrine for nebulization if you're using epinephrine to counter it?
Yes, ma'am. You can take 1 ml along with 3 ml of normal saline, ma'am. Then you can put it in the nebulizer. Then you can nebulize it, ma'am.
You mean 1 ml means 1 milligram?
Yes, ma'am.
So would you prefer a racemic epinephrine?
Yes, ma'am. It is books suggest racemic epinephrine also, ma'am.
Yes. Thank you. So my personal question, I don't think there are any more questions in the audience. Audiences are free to ask questions. So my question was, do you think that, is there any recommendation regarding the intracuff pressure? Because while the patient is intubated and ventilated, because in many instances it is seen that post-op pneumonia is associated occurs because of aspiration,
yes,
microaspiration more so.
Yes, ma'am. But
so is there any recommendation for intracuff pressure?
No, ma'am. Per se, in any, there is no recommendation in any of this literature, ma'am, for cuff pressure in particular.
Okay, so I was reading somewhere it has to be kept around more than 20, around 20 to 24 centimeter water.
Okay.
And I would like the audience to enlighten me further on this. The other question was, do you think that the type of endotracheal tubes we are using, they might have an influence on the increased occurrence of pneumonia post-operatively? If we are using ventilating the patients for a long period of time.
Yes, ma'am. We are routinely using PVC tubes, ma'am. I don't have any correlation between the tube and occurrence of post-operative pulmonary complications.
I will request our august audience to please comment on their experience with the use of PVC tubes and increased occurrence of post-op pneumonia. Because I was reading in literature, somebody wrote a review article in IJA, which has come out in the year 2015, that they have seen that they have quoted a study actually, and they have said that use of polyurethane tubes are probably better than PVCs, because PVCs tend to have longitudinal channels along the cuff side, and which can lead to microaspiration.
Okay.
Yeah. And the other thing is, are there any scoring systems to predict, post-op pulmonary complications?
Yes, ma'am. Actually, it is not mentioned in any of the textbooks, ma'am. But literature, they say that ARISCAT, periscopes, and they characterize into low risk, intermediate risk, high risk, and the factors are which I have talked about, ma'am, like age, any recent respiratory infection, smoking, any COPD.
You mentioned about TRALI. So, did you find in any literature as any preventive strategy or drugs which can be used to prevent, or to counter this effect of transfusion-related acute lung injury?
No, ma'am.
What is the cause primarily? What is the pathogenesis, if I may?
Primarily, it is due to the plasma blood-related products, ma'am.
Okay.
So
I think it's the activation of platelets and
yes,
release
ma'am,
vitamins and lots of all those factors. So in one of the publications by the some Canadian journal, they have said that they have seen that in a case of huge massive bleeding and followed by which there was they transfused a lot of blood. They found that use of tranexamic acid, which is an antifibrinolytic, probably kind of prevented TRALI, and it kind of reduced, helped the child come out of TRALI. So
okay,
maybe more studies may need to be done on that.
yes, okay.
So the audience is open to questions. The session is open to questions if anybody has any.
Dr. Vijayalakshmi, it's a very good
Yes, sir.
presentation.
Thank you, sir.
It's just a comment. See, there was a discussion about the tubes, what tube,
Yes, sir.
polyurethane and PVC.
Yes, sir.
In our center, we use, if there is abdominal surgery, when the patient requires longer ventilation, we use a tube with subglottic suctioning. It's slightly expensive, but these micro aspirations can be prevented.
Okay,
because
sir.
usually the secretions will stagnate near the
Yes, sir.
so there is a subglottic suction tube is also available. And somebody, I think Dr. N.T. Suresh has asked about micro cuffs tube. What is your experience, micro cuffs?
Yes, sir. Nowadays in pediatric, while we were doing PGs, we used only uncuffed tube in the for pediatric age groups less than 8 years. But nowadays, the literature tells that and use of micro cuff in the pediatric population also. Chance of aspiration is less. But personally, I have not used micro cuff tubes.
Sometimes when you use ML scopy, my MLT tubes are there, microlaryngeal tube, which also has a smaller cuff. Because if the surgeon wants to operate in a larger area in the trachea, so the cuff is small, and then the operative area will be more for them. If the cuff is
They'll
big,
have
then
more
it is
workspace.
difficult.
Yes, sir.
It is
More
available. These are the two areas I can think about it. But definitely it is not superior to a normal cuff because it can cause increased pressure.
Yes.
The micro cuffs can cause increased pressure. Yeah. Okay.
Dr. Satish, if I may add, you were talking about tubes which have a provision for suctioning, supraglottic suctioning. I think probably placement of NG tubes should be made, we should be using more and more of NG tubes. That can also help us prevent this particular complication.
Thank you.
Dr. Natarajan Bhaskar is asking, is there any role of surfactants in adults? Dr. Vijayalakshmi.
No, ma'am. Surfactants. No, ma'am.
I have also not found it in any literature. I mean, I would like the audience to enlighten me, please, if anybody has any information.
Only if there are cystic fibrosis or any other congenital problems, then the surfactants has a role. Otherwise, in routine conditions, there is no role of surfactants. You should prevent the injury. That is the best way.
Okay. Is there any other questions?
If Audience, if there is any more question, if not, I think we can close the session and I like to hand over to the organizers. Thank you.
Yeah, thank you. Thank you.
Dr. Sai
You all had a very
Gopalakrishnan,
good
sir,
academic
any question?
feast.
Dr. Sai Gopalakrishnan, sir, is one of the moderator, whether he wants to ask something.
So only one comment regarding the use of HFO. I think during the COVID period, one of the thing is which is mostly used without any justification is HFO, especially in post-op pulmonary complications. What I feel is we should know when to, as Dr. Lynette mentioned, it's not a replacement for non-invasive ventilation. And we should use it judiciously, and we should know when to go for non-invasive. Suppose if the PO2 is not coming up, we should not continue with the HFO, because one of the main thing is it is very patient comfortable. Patient feels more comfortable with the HFO rather than with the non-invasive ventilation. But ideally, we should know when to go for non-invasive. I feel that the HFO was mostly misused during the COVID period, and the amount of oxygen it consumes is also enormous. It's just a comment.
Thank you. Thank you, sir, for your additions.
I think there are two questions.
Yeah.
In
Bhaskar,
the
sir, shall I?
Madam, there are two more questions in the chat box, madam.
Okay. Okay.
One of them, I think, is the role of NAC for mucolytics in ICU, and the other is role of venous Doppler in bedridden patients to prevent pulmonary embolism. Your comments, Dr. Vijay Lakshmi?
Yes, ma'am. Venous Doppler, if we think that routinely we are not using venous Doppler, ma'am. If we think that patient is symptomatic, we doubt it means we can go for venous Doppler to rule out thromboembolism.
And maybe if a person is on prolonged mechanical ventilation, operatively, we can use prophylactic LMWH. So that is one thing. And the other question was role of NAC for mucolytics in ICU.
So it can we can use it, ma'am. We can use it as a inhalant also. It helps to thin out the mucus.
Yeah. And also in case when the patient is on prolonged ventilation. Humidified oxygen, yeah, that is very important also. So over to the organizers. I think there are no more questions.
Madam, as academic chairman has left on urgent work, I request Madam, President Madam, to give the concluding speak on the academic part, Madam, so that we can
Thank
go
you,
for the next
Bhaskar.
part.
Thank you, sir. Thank you. We had a very good academic feast. Thank you, chairpersons, for your excellent chairing. And also, at the same time, you have contributed your knowledge. Thank you so much. Very good presentation by both speakers, Dr. Vijay Lakshmi and Lena Thomas. I think we can conclude the session, Bhaskar, sir. A vote of thanks by Giridharan, sir.
Madam, next we have got the city branch report by Dr. Palraman, Madam. Shall we go with it, Madam?
Yeah. Sorry.
No issues, Madam. Thank you, everybody. Now we go for the final part of our program. I call upon Dr. Palraman Krishnan, Honorary Secretary for Thoothukudi City Branch, ISA, to go ahead with the city branch report.
Thank you. Thank you.
Dr. Balram, sir, welcome.
Yes, sir. Yes, ma'am. Good morning, everybody. Greeting from Thoothukudi Society of Anesthesia. I invite everybody for the mind-blowing interactive session. Again, I thank State Office Bearer for giving opportunity for our branch to participate in the academic session. Our city branch inaugurated on 31/7/2022. The auspicious function was conducted in a grand manner along with the highlight CMC. For inaugural function, chief guest, then President Dr. Venkatagiri addressed the Zoom platform. Our national secretary and one of the governing council member, Dr. Bala Venkat, sent a message through the mail. and our our state office bearers, every person, President Dr. S. Kumar, President-elect Dr. Amazarani, Honorary Secretary Dr. Bhaskaran, Honorary Treasurer Dr. Giridharan, and Governing Council member, State Governing Council member Dr. Ganesh Prabhu, all are came, and followed by the CMA program, followed by the inaugural function. CMA program, we conducted a CMA program. In CMA program, Dr. M. Kannan, retired professor, Tirunelveli Medical College, and Dr. M. Selva Kumar, professor and HOD, Madurai Medical College, gave a lecture. And then on behalf of ISA Thuthukudi, we conducted a quiz program after celebrating a World Anesthesia Day on October 16th, and we presented a cash reward to the winners, 5,000 for winners and 3,000 for runner. And I'm happy to inform you that we have a plan to have a academic meeting periodically. Thank you, everyone. Thank you, sir.
Thank you, sir. Thank you. I really appreciate the work done by the Thuthukudi city branch, which is a new branch that has been inducted into the Tamil Nadu ISA armamentarium. I really appreciate the work that is being going on. Please continue the good work, sir. With this, we are coming to the end of this session. I would like to call upon Dr. Giridhar, our Honorary Secretary, to deliver the vote of thanks. I think yes, one for attend urgent work. Madam, can I proceed with the vote of thanks, madam?
Yeah, you can.
Yeah. Good morning, everybody. I would like to thank all the participants who have been who attended this online program. This is a visionary program by Tamil Nadu ISA for updating the knowledge and as well as to get the credit task, which has been mandated by the Tamil Nadu Medical Council. So we are very happy that we are able to give a lending hand to our members to get the credit task. And as far as the topic today, it's a very good PG topic as well as very useful for the practitioners. If the PGs have attended, who have attended this online program, definitely they will be able to take an essay question very easily in any university exam. And as far as the consultants, I would please recommend them to kindly invest in higher-end gadgets, especially go for a workstation in your place so that you can provide a safe anesthesia, and go for monitors with ETCO2. You please insist with the hospital that ETCO2 is mandatory. We need ETCO2 because many procedures are being done. You will be able to, because the topic we discussed today, one of the parameters they are quoting is the ETCO2. So you please tell them ETCO2 is a very, very important one. We have to have it in the hospital to have a safer working environment. So I request our members to kindly recommend to the hospitals they work to go for a safer anesthesia environment. And I would like to thank both the speakers. They dealt the topic very nicely, and as well as the moderators giving space for a very good discussion to happen. And I would like to thank our academic chairman, Dr. Kumar sir, for taking the topic, as well as our president, madam, helping in getting this topic in a good manner. I would like to thank Tamil Nadu Medical Council observer for this program, Dr. Tirunavkarsu, who is attending this program, and also thank A1 Logistics for helping in conducting this online program without any interruption. Again, I thank all the attendees for this program, making this as a successful one, and also encouraging us to continue with our online program. Thank you. Thank you, everybody. We can close the session, madam. Thank you, madam.
Yeah. Thank you. Thank you, Shilpa. We can close.
We can close.
Thank you,
ma'am.
everyone.
Thank you. Thank you, sir.
Thank you, ma'am. Thank you, sir.